Hi, Dr. Saladino. Thank you so much for coming on the Thrival Nutrition podcast. How are you?
Doing great. How are you?
I'm good. Thank you so much for coming on today. I know we're talking about depression. This is a big topic. So before we get started, introduce yourself, who you are and what you do.
So I'm a classically trained MD. Went to medical school in Arizona at the University of Arizona, where there's a real focus on integrative medicine. And before that, I actually was a PA. I worked in cardiology as a physician assistant for about 4 years. During my time as a physician assistant, I got really interested in functional medicine and saw how the model of mainstream Western medicine was really breaking down, unfortunately. What I was doing was mostly providing medications to people with symptoms and not really getting to the root cause. So at that point, I decided to go back to medical school. So I finished medical school in 2015. Now I'm in my last year of residency, which is a 4-year process at the University of Washington in Seattle, and I'm in psychiatry.
Nice. That's so funny because initially I was going to school to be a PA. And I remember taking pharmacology, and I remember basically just being taught if they have this, this is what you give them. If they have this, and I was just so turned off by that.
Right.
That actually made me kind of have a change of heart and be more into preventative. So I kind of changed majors and went into nutrition.
That's awesome. That's so good to hear.
But I hated that. That was one class. I loved immunology and all these other things about it, but it was just the treatment, totally scared me off of I am not doing that for the rest of my life.
And I think that's, Western medical education builds on that, and there's some framework there, but I think that functional medicine really takes that a step further and starts to look into the root causes of these things. And that's hopefully, and I think that's really where medicine is going. It's this gradually growing interest in the populace, and it's exciting.
I think so. I think it's definitely going that way. I feel like it's kind of getting a name out there. People are really wanting to dig deeper. Not everyone, but most people that I guess that I'm around. I hear they question, why is this happening?
That's the important question, right? That's the most important question. And, Mark Hyman has said this, and just that functional medicine is about asking why and not what. Western medicine really asks what. And I see that in psychiatry. I saw that in medical school. It's all about what. What is the diagnosis? Does this person have depression? Is it major depression? Is it anxiety? Is it OCD? Is it bipolar? And then in Western medicine, once you know what something is, you feel like you kind of pat yourself on the back and you're like, I'm good. I know exactly what to do here. I have my medications and this is what we do. And that gives us some security. But if we don't ask why, which is really the scary question and the exciting question, we're not getting to the root cause.
Yeah, exactly. And I know mental health is huge in the US, and I'm glad we're talking about depression because I feel like the conventional approach, while it has its pros of maybe alleviating or helping in just a short term, even if necessary, the functional medicine approach is so much more needed for long term. So as you move through your finishing your residency, can you tell us what you've been seeing a lot of?
Yeah, so like I said, residency in psychiatry is 4 years. And the first couple of years of residency are mostly in the hospital, and you're seeing very sick patients with acutely psychotic symptoms, profound depression, refractory depression, people who are acutely suicidal or post-suicidal attempts. And so the first 2 years of residency are mostly in the hospital, seeing patients out of the emergency room and inpatient psychiatric units, most of which are locked. For the safety of the patients. These are patients that are very depressed, very psychotic, very manic if they're bipolar and have mania as a symptom, or people that are really, really sick. And then in the third and the fourth year, it moves to more of an outpatient perspective, which is what most people are probably familiar with when they think of psychiatry, seeing patients in the office who are not people who are acutely psychotic, hallucinating, or suicidal, or profoundly depressed, but have they're doing a little better, but they have sort of chronic, moderate to low level symptoms that we're trying to address. And unfortunately, which is part of most of what fuels my interest in functional medicine, what I see in these situations is people don't get better. The first 2 years of residency on the inpatient side, it's a lot of putting out fires, for lack of a better term. People come in, they're acutely depressed, and we try to do a little bit to put out the fire, but we can't fix the problem in the hospital, and then they go out. And then often they come back. And so it turns into this revolving door. And a lot of medicine is like that, unfortunately. And then over the last couple of years on the more outpatient sphere, I see the same thing. People won't get better. And like you said, you know, people sometimes get better for a short amount of time with meds, but meds don't help everyone.
Yeah.
And some people get worse with meds. And then almost inevitably with meds, there's a crash or they stop working or there's other problems that occur. So this is where I think there's a real need for functional medicine, especially in mental health. And that's what's so exciting is that there's not a lot of conversation about functional medicine in the mental health sphere and vice versa. You know, not a lot of people are talking about depression and anxiety from a functional medicine perspective. And certainly within my residency, you know, at the University of Washington, I work with, you know, other academic physicians in a very prestigious institution. And there's, unfortunately, I'm hoping to change this, but there's no conversation around functional medicine.
Yes.
So
I feel like we look at depression and anxiety like so surface level, and also just focusing like strictly on the brain, which understandable, but like, I know we'll talk about gut health and all that stuff, but it's so interesting when like you bring up, let's say, gut health or something just out of the norm. They're like, what are you talking about? Like, there's not much conversation about it, and there should be. Yeah. So tell us a little bit about the traditional treatment for depression. Give me like a pros and cons list of if it helps, if it does. Like you kind of covered a little bit, but.
Sure, yeah. So depression is interesting. So trying not to get too much into the weeds, but the way we work in mainstream psychiatry is we use what's called the DSM, which is the Diagnostic and Statistical Manual, which is a sort of our decision tree in psychiatry. And it's a big, thick book, and it's had 5 editions, and it's been around for decades, and it gets revised. And it's when all the you know, bigwig psychiatrists sit around and they say, how are we going to actually categorize mental health illness? And is this going to be a real illness? And is that going to be a real illness? Or is that not a real thing? And so what's so interesting about psychiatry is that we're dealing with things that are not as concrete as we do in other medical specialties. You know, if you have a tumor in your thyroid, we can see the tumor and we can take it out and we can do pathology on it. We can do histology. And if you have something in your gut, like a polyp or diverticulosis, we can see those things. They're actual real things. If you have atherosclerotic plaque in your heart, we can see those things. But in psychiatry, we can't see it. It's completely amorphous. And so we're sort of, you know, we're really trying to, like, you know, imagine the ether and imagine these abstract concepts, which are real, but very difficult to kind of put into boxes. And so if we're thinking about depression specifically, the way that we characterize depression in psychiatry, in mainstream psychiatry, is there are criteria that say this is major depressive disorder, and it's 5 of 9, neurovegetative symptoms, low energy, low concentration, thoughts of suicide, decreased sleep, things like that occur for 2 weeks straight. So if you have these very subjective, well, I guess it's objective, but if you have these symptoms, we would characterize you as major depression. And what's interesting about that is that you can have lots of depression that looks different ways and come from different places that can fit into that perspective. And so that's what we do in mainstream psychiatry is we look at symptoms that people are coming in with and we say that's major depression. And then once we say it's major depression, we have a series of treatments that we can use, which may be medications. In fact, most of their medications in the beginning, and the medications are SSRIs, selective serotonin reuptake inhibitors, or SNRIs, serotonin and norepinephrine reuptake inhibitors. And there are some older drugs that work on serotonin a little bit differently, like mirtazapine or Remeron, things like that. But usually when people come in with depression, if they're diagnosed with depression, whether it's major depression or it doesn't fit into that criteria directly, they'll get a medication. And this is where it gets interesting. You know, about 1/3 of the people get better with a medication. About 1/3 of the people don't have any effect, and about 1/3 of the people get worse. So it's worse than a coin flip. So that's what's scary about giving these medications. And that's just in the short term. So there are polymorphisms, which are genetic, unique variations in what's called the serotonin transporter that can possibly predict who's going to respond to SSRIs badly or poorly. But that's not even perfect either. But what we know is that some people get worse, they get more anxious, they get more suicidal on these meds. And for some people, they don't feel any effect, no good effect, but they may get side effects. So the problem with most of the medications we use in Western medicine is they all have side effects. SSRIs are no different.
And let's not talk about like the nutrient depletions that they cause.
Right.
Every pharmaceutical does in some way. And so I know antidepressants definitely do. And I don't hear that often at all. Like if you're on depression medication and people are on it for a long time.
That's the problem, is they get stuck.
Yeah.
And that's the problem. That's an interesting thing about Western medicine, is that people get on medications and then we as Western physicians are very hesitant to take people off. We're just afraid that everything's going to crash. And that, I mean, that's a great point you bring up there too, is that the side effects of, well, the withdrawal from SSRIs is not pleasant. Anyone who's been on it and stopped knows you get brain zaps and things are all kinds of messed up in your brain, because what these medications do is they increase serotonin in the synapse, which is the space between two neurons. And when they do that, your body, they do that by inhibiting the transporter, which removes serotonin. And when you do that, your body will downregulate the transporter trying to adjust, because your body's trying to achieve balance. And when you mess with something, your body's going to adjust a certain way. And then when you stop a medication, there's not enough serotonin in the synapse. People can get more depressed or brain zaps or more anxiety. And so getting off them is no easy task either. So for a third of the people, they do help in the short term though, perhaps. And the problem you run into there is, of course, the thing that we think of in functional medicine, that we're not actually fixing the problem.
Right.
And the problem is probably more than just low serotonin in the synapse. That's what's called the monoamine hypothesis. And that's really going out of favor, that we don't think that depression is just not enough serotonin anymore. It's complex. And we can talk about functional medicine models of depression in a moment. But then when people who may get some benefit from the medications, they often stop working later on as the body adjusts, or they may develop bad side effects, which can be anything from GI side effects to sexual side effects, low libido, memory side effects. And these, then you run into a real problem. You know, if someone is depressed and they're taking a medication which is treating the symptom but not treating the cause, they have to weigh, well, is my mood more important than my connection with my partner, or, you know, my sex drive, or, you know, regularity in terms of GI stuff. And it puts people in a really tough spot. It's like, you can't fix it.
Yeah. And if that's not a red flag of just being able to get off of it and feel good and feel fine, then I don't know what is. Obviously, it's not solving the problem. And we just always need to be looking for more, which makes me so appreciative of doctors like you that are willing to look a little bit deeper and take that care that people need. And there's not enough doctors yet.
Yeah. I mean, you brought up a great point that for some people who are in a really bad state, these medications can be good and they can be helpful in the short term. I don't think all medications are bad. Certainly think that medications have a place. I just think we need to understand what they're doing and what they're not doing. And we can't see these medications as the fix. If people are really in a bad spot, then I think that if a patient is not in a good spot and is not able to make lifestyle changes, then perhaps the medications serve a purpose. And I certainly see people like that.
Yeah.
They're too busy, or their life is falling apart too much to make lifestyle changes with sleep or meditation or food or any of these things. Then maybe a medication can help short term, but if they stay on it long term, it's really going to create problems.
Yeah. Oh, I'm so thankful for like Western medicine, like emergency medicine. I mean, obviously that helps a ton, and I love knowing that we have it. But these acute, even chronic conditions of just everything from depression, diabetes. I mean, there's just so much influence on our lifestyle. We just cannot not look at it, because let's be honest, a lot of the diseases out there are based on because of our lifestyle, whether it's nutrition, whether it's stress, whatever it is.
I mean, you know, I don't think anyone can really quantify this, but you hear statistics, 97% are lifestyle. I mean, 3% or maybe not, but the vast majority are lifestyle. And you know, the 3% that are not lifestyle, I think, is where Western medicine shines.
Yes.
And I'll give Western medicine all the credit there. You know, in emergency medicine and surgical specialties, in acute coronary syndromes, this is amazing and miraculous, and it's changed the way we live.
Yeah.
But 97% is probably lifestyle, and Western medicine doesn't do that well. You know, and that's from experience on the inside.
Yeah. And I think too, we just lost faith in our body, of being able to understand that our bodies are designed to win. They're designed to be able to adapt to things. And I think sometimes losing that faith and putting it in medicine kind of brought us down too, because some people just don't realize the power of food or the power of exercise or the power of nature. I mean, it's just insane that we've lost these foundations of just human living in general.
We've become so disconnected. I mean, it's cliche, but it's true. We've just become disconnected from those things, and it's really sad.
Yeah. So diving into the functional medicine aspect of nutrition, I know that there's tons to look at, whether it's methylation, gut health, nutrient deficiencies, inflammation, things like that. Get us and just educate us about it.
This is where it gets really cool, and this is the stuff that's really interesting. So if we go back and we think about the Western perspective of depression, it really just sees depression as one thing. But I think that, you know, if we're looking through a functional medicine lens at depression or any psychiatric or mental health thing, we really start to see quickly that there's not just such thing as one depression. That's really a mistake to characterize it that way. And when we think of depression as multiple entities or multiple root causes creating different types of depression, then we can start to think like, oh, there are multiple things causing this. I think the most basic type of quote unquote depression is probably just we're stressed and we're going through a hard time. And that type of depression we might characterize as something like adjustment disorder. And that doesn't respond to medications. And I don't think people should get medications for that. So that's a really important thing, that if people are in a space where their life is very stressful and they've not had depression before, it's probably normal to feel low mood. It's okay to feel low mood. Sometimes it indicates that we need to do work in our lives, whether it's a toxic relationship or we have a passion for something and we're not enjoying our job, or our living situation is messed up. Depression or low mood can be really helpful, sort of like nudging from the outside world around us to change our life and find something that makes us happier. And that's not something you should treat with an antidepressant. That's a good thing in our body and our mind and, our soul saying, change your life.
That reminds me of just fevers too, just in general, of just like bringing down the fever. When we bring down the fever when we're sick, we're ultimately not listening to our body telling us to rest, lay down and not do anything.
Right.
But when we just break the fever, we're like, oh, we're feeling better, we're sick. But like, I'm not feeling as happy, so I can go out and do things. So we're going against the grain of just like listening to our body. We're totally
missing it. Yeah. So some depression is really helpful for people. And I think that this is where working with a psychiatrist or a therapist or a psychologist can really help sort this out. But it has to be someone that's not just going to have a knee-jerk reaction to give medications, and somebody that's really going to listen and take the story. And there's plenty of great people out there, but to really sort out, like, is this like depression that I'm going to treat with something either inflammation or methylation, we'll talk about all those, or is this just like your life is stressful depression and you need to meditate and you need to like do self-care and you need to sleep more than 4.5 hours a night, because all of those things will cause people to feel down. But in mainstream psychiatry, we don't do a great job of sorting that out. And that's the first thing, is that some depression is helpful and is just telling us, change your life, do these things, take more care of yourself, take better care of your family, find time to slow down. That's important. And those are great things. And we shouldn't just quash that with medication that's just going to make us think everything is okay. And then if we get into other types of depression that we would call biologic depression, then this is where we get into the multiple flavors of depression and the multiple ideas around what could be causing depression. That if it's not that your life is stressful, if we've done all the self-care things, if we're in a good space, if we're having a great community and we're in satisfying and nourishing relationships, and we're still feeling depressed, maybe this is a biological thing. And then we have to get in and look at the machinery of the body on the inside. And this is, I think, where functional medicine will really help advance the paradigm. And so I would say that there are probably maybe 6 or 7 different types of depression here. And this is where you need a functional medicine doc to sort this out. And I think the first one that we always come back to is the gut. And we know that chronic inflammation can cause depression. And that's a pretty radical thing. But there's a ton of evidence in the literature now to suggest what would be considered neuroinflammatory depression. And we can look at neurotransmitter intermediates in the urine that suggest what's going on in the brain. These are tryptophan metabolites like kynurenine and quinolinic acid. We can look at ratios there that suggest that there's inflammation somewhere in the body, and that inflammation is communicating with the brain across the blood-brain barrier. Cytokines from the body can transmit across the blood-brain barrier and then trigger what are called microglial cells, which are brain-derived macrophages. So the brain-derived immune system, it sends them crazy. And what we see is microglial activation in some people with depression. And that would be considered neuroinflammatory depression. And this is a really interesting piece of this equation, is that SSRI medications, the mechanism is not fully understood, but there's some evidence that they may actually, and this is not necessarily a good thing, but it may be why they work, they may change the cell signaling in microglial cells. So there's some evidence that at a transcriptional DNA RNA level, SSRIs may have a mechanism by which they can turn off activated microglial cells. So that's a really interesting thing, and it kind of lends support to this hypothesis or this idea that there's such thing as neuroinflammatory depression. Again, they're still not great medications because it's not fixing the cause of the inflammation.
Right.
If
it's
just inflammation, we have to fix the cause, right? We can't just turn down the inflammation, which is, I think, one of the colloquial misunderstandings in the popular press, that like we can just take a bunch of anti-inflammatories for our inflammation. We can just do turmeric baths, you know, and just take a pound of turmeric a day and just shut off all the inflammation. Well, no, because the inflammation, again, is telling us something. This is communicating to us. So,
yes.
So there's a neuroinflammatory type of depression probably that's you can look at through organic acids in the urine. You can get a sense of it through systemic inflammation. And then, you know, that begs probably the $64,000 question in all of functional medicine, which is where is inflammation coming from? And usually that's the gut, but it can be other places. And maybe I'll just back up a moment and, you know, make sure that people listening are familiar with this term inflammation. I think we hear that term a lot, but in medicine, it's not talked about, like, what is inflammation and what does it mean and how do you get your hands around it? And I would just offer, the way I understand inflammation is more of an immunologic overactivation. It's like your immune system has just gone haywire. So it's sort of this cytokine stew, this cytokine milieu from the immune system. And cytokines are molecules that cells of the immune system use to communicate with one another. And so all of these cytokine signals, like text messages that all the immune cells are sending to each other, are signaling danger, danger. It's like everyone in the immune system is texting each other and saying, there is a bad thing happening on the first floor of this building, and everybody gets all worried and stressed and up in a roar. So
I love that little comparison. That's really
good.
Good.
Inflammation is people freaking out. It's the immune system going crazy and being unhappy and saying, there's a real problem happening here, and everybody's really stressed and running around, like, you know, doing this kind of thing. That's inflammation. And so usually it's coming from somewhere. They're not just doing, sometimes this happens for no real reason, like autoimmunity. You know, they can say, oh, everything's going crazy, but it's kind of just reacting to something that's friendly. But sometimes it's actually reacting to something that's bad and people are just freaking out. But it's this cytokine stew, this cytokine communication signal that's happening throughout the body. And like I said, that transmits across the blood-brain barrier. So that's inflammation, and it's usually in the gut. It can be other places. And so you'd want to, you know, when I see somebody that I think has neuroinflammatory depression, the first thing I'm going to do is look at their gut.
Yeah.
And which is pretty radical and pretty cool for psychiatry to start thinking that the roots of an illness, which is in the brain, can be outside of the brain.
Yeah. I mean, I feel like that's kind of where Western medicine got it wrong, to where they're like just a gastro doctor, strictly stomach, psychiatry, strictly head. And I'm like, the body just doesn't, yes, we have those systems, but it doesn't work that way. They all
doesn't work that way.
Each other.
It doesn't work that way. I mean, you know, at a very macro level, you know, if you do surgery on someone and you open their abdomen, you will see a stomach and a gallbladder and a liver, and they are discrete entities. But at a more microscopic level, there is no distinction between these. There is an immune system which traverses all of them, and that's probably the connecting fiber through all these things, is that there are cells that move between every single organ in our body, and without exception, including the brain, even with the blood-brain barrier. So the brain is communicating with everything. My brain is communicating with my toe, for sure. So
yeah.
Totally agree.
I love they call the gut like the second brain.
Yeah, they do because of so many things that are happening there. And you know, I had a friend once who coined the term. He said it's the Balkanization of medicine. I thought it was a great term. Just this piecemeal separation, this Balkanization, this like we're drawing all of these borders between countries and we're separating it up in these little things. And it's a real problem, because then what happens is the gastroenterologist doesn't talk to the psychiatrist, doesn't talk to the endocrinologist, doesn't talk to the cardiologist, doesn't talk to this dermatologist, and they all need to be talking, and they're all wonderful, well-intentioned, intelligent doctors who just have been taught this paradigm, like you're saying, that's really false and is very handicapping. And so I think that within psychiatry, as much as any other specialty, we really need to imagine that the problems can be outside of the brain. And when we start thinking about that, like, whoa, the problem in my brain could be in my mouth. If I have periodontal disease, the problem in my brain could be in my gut. The problem in my brain could be, you know, somewhere else. That's incredible. And that opens up all these doors of things to look for. So.
Right.
Yeah.
That's just like mouth and heart. I mean, that's so interconnected, but you never, you know, it's a separate system. So
yeah.
Connected.
So then there's neuroinflammatory depression, and then there's also methylation, which is probably it's a buzzword now. Everybody's heard of it, or most people have heard of it. Methylation gets into looking at the genes, and certainly in my practice, I've seen people have real changes in depression, anxiety, and bipolar illness with attention to methylation. And in brief, methylation is the way the body moves around methyl groups, which are 1-carbon units in the body. The body derives most of the methyl groups from folate, in the diet or in supplements, and that can be affected by polymorphisms, which are, again, these single nucleotide genetic unique aspects of every one of us in the folate cycle. So there's this complex biochemical cycle through which we use folate, and we process dietary folate and other methyl donors like methylcobalamin, which is a form of B12, and we get that methyl group and we move it around the body. There's hundreds of reactions that move methyl groups around, whether it's detoxification using an enzyme called catecholaminomethyltransferase, or COMT, or the liver adds methyl groups to things to detoxify them. In the brain, we use methyl groups to make neurotransmitters and degrade neurotransmitters. It's really a currency, you know, it's like a nickel that the body is just putting in different slot machines all over the body. And you can only use that one nickel. And if the nickel is gone, then it can't run all the slot machines, you know, or it can't run all the machines that it's running with nickels. And it creates a real problem. And so you can also, it's pretty easy nowadays, or it's becoming more easy to look at methylation and to look at how well you're methylating. And you can look at ratios of things like homocysteine or S-adenosyl homocysteine to S-adenylmethionine. And people take supplements like SAMe, which is S-adenylmethionine, and SAMe is the methyl donor in the body. So you eat folate, it goes through the folate cycle, it goes through MTHFR to make L-methylfolate, and then homocysteine is converted to methionine. In the process, there's a methyl group placed on homocysteine to make methionine, then methionine is converted to SAMe, and that is the methyl donor for all these things in the body. So you can look at that as well. Then there's micronutrient insufficiency, which is another cause. All of the biochemical reactions in the body need micronutrients, whether it's magnesium or manganese or selenium or zinc or B3 or B2 or riboflavin or any of these things. The gears turn with micronutrients. And so if there are biochemical things missing from our diet, it's difficult to predict which could be missing. It has to do with genetics. Then the gears won't turn and the biochemistry won't work. So yes, looking at that can be important, et cetera, et cetera. So there's all these sort of subtypes of depression. And for people to say like, oh, here's an SSRI medication really just covers all that up when there's this real impetus or this real signal, like something is wrong, let's fix it and increase long-term health. Because if we don't fix it, then surely whatever is causing this is gonna manifest in other ways later on.
Yes.
We know that with things like methylation and gut stuff. If we ignore it, it's gonna cause depression. And then if we squash down the depression with medication, then your gut is it's gonna manifest somewhere else.
Yes, yes. What are your thoughts on serotonin being mostly made in the gut?
Well, it's definitely made in the gut. It's definitely mostly made in the gut. I think I think there's plenty of evidence for that, you know, and there are enterochromaffin cells there. And whether or not the serotonin made in the gut crosses the blood-brain barrier is questionable. The blood-brain barrier probably keeps most of the serotonin in the body, and we make serotonin in the brain as well. So, you know, but there is a lot of serotonin made in the gut, which is why SSRIs cause GI side effects, because they increase serotonin in the gut. And then serotonin is a stimulant, it's a prokinetic in the gut. A lot of medications that push things through the gut faster work on serotonin receptors in the gut. So serotonin will make the gut move faster, but that may not necessarily all be a good thing. So
right.
I don't think a lot of the serotonin in the gut crosses the blood-brain barrier. It could a little bit, but generally those two populations of neurotransmitters are separate, because there's also dopamine in the rest of the body too, and norepinephrine. We have hormones in two places and they're kind of supposed to be separate. But the other thing is that most of the immune system is around the gut, which is pretty crazy to think about too.
Yes.
Just a single layer of cells separating, you know, the lamina propria, which is where the majority of our immune system resides, from all the foods that we eat. And that's where, I think that's a reasonable idea of, this is where all this inflammation is coming from. These immune cells are just going crazy when things go wrong in the gut.
Right. And we're so overfed and undernourished with all the foods that we have available to us. And, you know, 75% of the grocery store is just processed foods that don't even have like the nutrients that we need. And so if you look at the majority of the population, that's what they're eating. So they're not even getting nourished, like you said, to even activate things that need to be activated.
It's scary. Yeah, we're overfed, undernourished, and then all the overfeeding is a lot of toxic things, which can cause leaky gut and all kinds of problems.
Yeah. So what actions can our listeners take to help, their depression if they're struggling with it? Obviously working with a doctor and
Right, right. So I definitely would
where you're
work.
at, but
I would, as a physician, I have to say that none of this can be construed as health
yeah.
advice.
Yes.
Always talk to your doctor about doing any of these things. Don't stop your medications without talking to your doctor. But if your listeners are interested in functional medicine approaches to this, I think that, I'm sure that you have a lot of resources. They can reach out to me or other functional medicine practitioners in the community. But, the idea is start with basic things. Start with lifestyle. Start with food and sleep and meditation and stress relief. And, I think there's lots of paradigms about how to eat and how it's best to eat. But I think that the basics around food are pretty straightforward. The best quality food you can get, the most whole ingredients you can get, the more organic, the better. We know that glyphosate and toxins like that are a big deal. It's super important to sleep. That's completely foundational. If people are not sleeping 7.5, 8 hours a night, then really have to take a solid look at why that's not happening. And that can be an indication there's other things going wrong as well. I think some form of stress relief in terms of meditation or things that you enjoy in terms of exercise are important. So all the basic foundational lifestyle stuff. If people need more than that, then I think that they should look for either a functional medicine doctor or a psychiatrist who does functional medicine to start sorting some of this stuff out and thinking, is there evidence of GI stuff going on that could be leading to neuroinflammation? Is there a methylation related issue here? Are there micronutrient insufficiencies? Should we do some nutritional testing? And that's really the next level. And once you start doing that, you're really popping the hood of the car and looking at the real causes of these things. And once you have those in mind, I think it's totally possible to get off medications under the supervision of a physician safely. But I think that people should know that medications are usually not needed for these things. As we said earlier, sometimes they can be helpful, but at least in terms of depression, a lot of times we can get off medications. If people are on mood stabilizers and they're bipolar, then it's a much more tenuous proposition taking them off mood stabilizers. Or if people have psychotic disorders like schizophrenia, it's a little tricky to get off that. But for the most part, when we correct the underlying stuff, we can remove the medications, which is really the goal. Let the body do it.
Right. Do you have any favorite tests off the top of your head that you love using on a functional medicine approach? I know you said the oats organic acids test. Is there anything else?
Yeah, I really like gut testing. I really like the GI map from Diagnostic Solutions. I think that that's hugely important. I think that, I think that you got to look for toxins as well. I don't see it in a ton of people, but every once in a while, if there's a heavy metal burden, you can look for that. I think micronutrient testing on top of the oat is important. And some companies like Genova make profiles that have some of both that I think are pretty helpful, like the Nutri-Eval. And so, yeah, that's usually where I start, and then you kind of delve in from there. Once you get into methylation, the testing is fairly specific and a little bit complicated. Doctor's Data has a profile that's a methylation profile that looks at SAMe to SA ratio, which is acetylmethylhomocysteine. And then there's another lab called HDRI, Health Diagnostics Research, that has a full methylation panel that has all kinds of stuff on it. But I think at that level, you really want somebody that's pretty comfortable looking at all the stuff. And then I think it's also interesting to look at 23andMe, look at your SNPs, find someone who can help you sort through that. And those all kind of come together, especially in terms of methylation stuff.
Yeah. I'm the one that has like the double homozygous MTHFR.
Oh, me too. But it's totally, but it's knowledge is power, right? And then, it's pretty easy now to say, oh, I'm homozygous for 677, C to T, MTHFR. Okay, well, what is my SAM to SAR ratio? How much L-methylfolate should I eat? I think you can definitely get too much methylfolate, which is part of the nuance around methylation. But, once you can dial that in or just get a lot of folate-rich foods and avoid folic acid supplements, which can potentially block receptors and inhibit enzymes, then you can really fix it.
Yeah. For heavy metal testing, what are some of your, I know there's different ways from hair and things like that. Is there a way, what you recommend?
Heavy metals are pretty tricky. I think that if people have a real history of exposure, if they grew up near a smelter or worked in a paint factory or are really suspect like a major exposure, have been around leaded gasoline, then I think you have to do provoked urine testing for heavy metals with a chelating agent like DMSA. And that's prescription now. I think that hair levels are valuable, but it's difficult because sometimes your body won't push all the heavy metals into the hair if you're not able to excrete them or not able to process them. So hair is not the greatest thing. I think if you can take hair and maybe urine and maybe blood levels all in connection, then that's the best thing. And there's some companies out there that'll do multiple. You can look in the blood, you can look in the urine, and you can look in the hair and get a sense of how well you're excreting it. And then I know the Nuvitru Eval definitely has serum levels of heavy metals, which will give you an idea of current exposure. And, you know, I'm seeing a lot of mercury, more and more mercury these days. And I'm seeing a lot of tin, which is interesting. People are using these Keurigs, like a Keurig.
Really?
Yeah. Yeah, a lot of tin. It's these countertop espresso makers and have like tin piping, and some of the pods are tin or something. So I'm seeing people a lot of tin and mercury even in people who are just eating wild salmon. So
wow.
Yeah, it's kind of scary. And certainly if people go to the store and ahi is on sale, if they eat a bunch of tuna, then mercury is going to be really high. We know that these things will raise your mercury.
Yeah, which sucks too, right? Because there's such good benefits with that as well.
Right. And then, you know, that's a whole other podcast. And yeah, I think there are ways to mitigate it. You know, I think that there are benefits to fish, but I think that the sad truth, or you can make a real argument that we have really polluted the oceans. I mean, I think that if you could just eat fish, that would probably be fantastic, but we cannot just eat fish anymore because you'll just accumulate too much. I mean, there's a great podcast, Tony Robbins with Tim Ferriss, talking about, I mean, Tony Robbins, you know, absolutely had heavy metal poisoning.
That's crazy.
Yeah.
And I mean, you can't win with farmed raised fish either, because it's...
No, you definitely don't want farm raised fish.
No.
No, you don't want farm raised fish. You don't want any of those things. You know, one of the things that I think that I try to recommend to people if they like it is like fish eggs. You know, I feel like the fish eggs from small fish probably have lower amounts of the heavy metals. You'd have to actually do the testing, but I mean, sometimes I eat a kura, which is salmon roe, if I don't want to eat actual salmon, and that's full of phospholipid DHA. And, you know, if we're looking for the omega-3s, you can get it other places like the fish eggs. Or, I mean, I think eggs in general, if people eat eggs and are not sensitive, the yolk of the egg from like a good pasture-raised egg has a lot of DHA in it, as well as native cholesterol, tons of B vitamins. I generally recommend to people they are careful with the white of eggs, but yeah, there's ways to get similar nutrients. And then liver, you know, all the magic foods.
Something that we've just kind of stopped eating. We stopped eating nose to tail a long time ago, which is unfortunate.
All kinds of problems.
But thank you so much for coming on. Where can we find you?
So my website is paulsaladinomd.com. My last name is like salad and dinosaur, so it's SALADINO. So paulsaladinomd.com. And the Instagram handle is the same. So the Instagram handle is Paul Saladino, at Paul Saladino MD. And my email is paulsaladinomd@gmail.com. And I have a sort of a private practice in which I see people and do functional medicine with them too. So if anyone is interested, they can certainly reach out to me, and I'm happy to talk with them on the phone for a little bit and talk about goals. And we can do Skype consults and all this kind of stuff if people are in need of help.
Awesome. Thank you so much for coming on today.
Yeah, my pleasure. Thanks for having me.